preparation of a navigated cryobiopsy, the CT scan is reviewed before the bronchoscopy and imported into the dedicated planning software. The nodule is marked and an appropriate route to the lesion is selected. In this case, the team of Professor Lambers at Ordensklinikum Linz marks a nodule in the right upper lobe of a male patient for subsequent sampling with the flexible single-use 1.1 mm cryoprobe. Changes in lung anatomy that can occur after the CT scan and during the bronchoscopy itself can lead to a divergence between the expected and actual location of the target lesion. Factors that contribute to so-called CT-to-body divergence are, among others, lung volume differences, pre-procedural CT scan technique, anatomical changes, atelectasis, changes in chest muscle. To mitigate such divergence, several best practice techniques can be applied. These can relate to tip-tracked instruments and catheters, direct visualization, shape sensing technology, optical pattern recognition, cone beam computed tomography, and augmented fluoroscopy. Furthermore, tomosynthesis and radial endobronchial ultrasound are used for correction of CT-to-body divergence during bronchoscopy. This has proven to greatly improve accuracy of sampling. The bronchoscope is then inserted for airway inspection. The patient undergoes fiber optic orotracheal intubation with the flexible ET tube after sufficient pre-oxygenation and induction of general anesthesia. The ET tube is mounted to a dedicated holder to prevent dislodgement. An adapter is connected for jet ventilation and bronchoscopy in parallel. Several reference points are marked for automatic registration during the procedure. These are usually anatomical landmarks, such as the main carina. Automatic registration is carried out after initial airway inspection. The previously marked landmarks are reached with the navigation probe until the process is completed. The bronchoscope is advanced according to the previously planned route. Once the bronchoscope cannot be advanced any farther, it is locked in the dedicated scope holder. The navigation probe is advanced along with the extended working channel towards the lesion as per preoperative planning. They use a bronchoscope with a working channel of 2.8 millimeters. Since the distal end of the extended working channel includes a navigation probe element as well, the lesion can still be visualized by the system after extraction of the navigation probe. Radial EBUS serves to confirm the position of the lesion. A tomosynthesis is performed to mitigate the impact of CT-to-body divergence once the lesion is reached by means of electromagnetic navigation. To perform this procedure, the C-arm is slowly rotated under activated fluoroscopy from 25 degrees right anterior oblique to 25 degrees left anterior oblique. The nodule is marked in the resulting tomosynthetic image. The position is corrected in accordance with the navigation image. A special operating table made of carbon fiber is used to eliminate interference of ferromagnetic objects with the electromagnetic field. The holder makes it possible to fine-tune the position of the navigation probe. After the position of the navigation probe is adjusted, according to the corrected position, the navigation probe is extracted. The flexible, single-use 1.1 mm cryoprobe is introduced into the extended working channel. Under fluoroscopic guidance, it is advanced to the exact same position the radial EBUS probe was in before. Since deflection of the extended working channel's tip is only minimal, this reduces the likelihood of missing the lesion. Furthermore, tangential freezing allows for sampling in cases where the solid consistency of the tumor impedes opening of the forceps jaws. Freezing is activated for 3 seconds before the cryoprobe is extracted through the extended working channel. The freezing function remains activated until the sample has left the patient. Premature thawing induced by the patient's body temperature could lead to loss of the sample should activation be interrupted. With the help of the removal tool, the sample is gently removed from the tip of the cryoprobe. Forced removal attempts using forceps or sharp instruments should be avoided to preserve high quality for following examinations such as histology, immunohistochemistry, or molecular analysis. The conditions under which the sample is stored and transported should be defined as per institutional pathologist guidelines, taking into account the desired examinations. The bronchoscope is reinserted through the ET tube and advanced to the respective segment. No bleeding is seen in this case. Occlusion collapse with bronchoscope and injection of ice-cold saline are able to control mild or moderate bleeding in case they occur. Only severe bleedings that can cause hemodynamic instability would require interventions that exceed the possibilities of bronchoscopic control. Leaving the bronchoscope inside the airways facilitates bleeding management. In most cases, the extended working channel wedges the airway leading to the lesion and helps prevent blood from flowing to further pulmonary areas. Cold saline or vasoconstriction agents are readily available to support bleeding management in case they are needed. The frostbite study demonstrates that transbronchial cryobiopsy using a 1.1 mm cryoprobe through a sheath can be performed safely under standard flexible bronchoscopic conditions. It has a similar complication profile to forceps biopsy in the past.